Okay, hi, this is Michelle again. So we are going to be talking about mental health nursing assessment. So the purpose of psychiatric mental health nursing assessment is to establish rapport with the patient, obtain an understanding of the current problem or chief complaint, review physical status and obtain baseline vital signs, assess for risk factors affecting the safety of the patient or others, performing a mental status exam, assessing psychosocial issues, identifying a mutual goal for treatment, and formulating a plan. So we always want to know about the presenting problem. Why are they here and what problem are they having? Past medical history is going to be very important also. As we know, many medical conditions can mimic mental health disorders. For instance, Alzheimer's, or if there's a tumor in the brain, epilepsy. Some of the sexually transmitted diseases can have a change in mental status. Hypo or hyperthyroidism can cause symptoms that would indicate a mental illness. Sleep deprivation, nutritional deprivation, all of these things, all of these past medical history pieces can mislead us into believing that there's a mental illness when it actually could be a different diagnosis. Family history. We're going to gather some family history information on the patient. What we have found in research is that many of the mental illness diseases have been found to be genetic. So when you're gathering your family history, if you're finding that there's mental illness in the family, it will trigger you to think that, perhaps this is a mental illness with your patient. We're going to look at the mental health status exam, evaluating the individual's current cognitive process. Psychosocial issues. This is going to include subjective information in the assessment, focusing on the patient's perceptions and recollections of what's going on and in their general life. Gathering information on family, friends, education, work experience, coping styles, and spirituality or cultural beliefs. In the patient's own words, we're going to want them to tell us what is central or the chief complaint that they have. They're going to have to tell us if there's a history of violence or suicide or self-mutilation behaviors. Do they use alcohol or other substances? Is there, again, that family psychiatric history? Have they ever had any psychiatric treatment or taken medications in the past? What stressors do they feel like they are under at that particular time? And have they tried any coping mechanisms that have worked or not worked? What their impression is of the quality of their daily life. Their social background, including support systems. As we know, support systems are very important coping strategies for all individuals. Getting their impression of what their weaknesses or strengths are, and then setting some type of goals for treatment. Spirituality, religion, and culture are a very important aspect that we must not forget to assess when we are meeting with our clients, because it can be a benefit for us and could also, have some challenges with the treatment plan, excuse me. In our assessment, we may choose to use rating scales to try and help us determine where we think that individual is. And on Blackboard, you'll notice that I posted many of these such assessment scales that you can utilize when you're on the mental health unit for clinical, or just in general, if you are, trying to even work with some friends and family, you can utilize these assessment scales also. So the Beck, there's a Beck and a Zung depression scale. There's a geriatric depression scale. There's the global assessment of functioning. There's another one to test cognitive functioning One is the mini mental status exam, and the other one is called the slums. Again, those are posted on Blackboard. There's screening tools for anxiety, and then if your patient happens to be on antipsychotic medication, you'd want to be utilizing the AIMS scale, which is the abnormal involuntary movement scale, which is often a side effect of some of the antipsychotic medications. Age does make a difference. We already talked about that mental health can affect everybody on the age continuum. But for children, we may have to gather information from different sources, such as their caregivers. We may have to try and get the child to express their feelings, rather not in words, but perhaps in art or drawings, or acting or playing ways, because the child's not developmentally, the brain is not developed enough to be able to translate those feelings and emotions that they're having into words. So we try to use other kinds of strategies to try and get information from children about what is going on. Oftentimes, mental health disorders in children are going to have regressive behaviors, where they're functionally at one level, and then all of a sudden they start wetting the bed, or sucking their thumb, or having behaviors where they're regressing, where their speech starts to decline, or even their physical mobility, like their gait. So again, interviewing and observing the behavior. Now, adolescents, we have a little bit of a different concern with them. They are very, what do I want to say, they're skeptical of you at first, until you're able to, form that relationship with them. They're very concerned about what they share truthfully will be shared with their parents, and so they have a fear of punishment or repercussions from sharing truthful information. So our goal as the nurse is to make sure that they understand that the relationship is confidential. They understand that the records cannot be shared with the parents and that they are private. Exceptions to confidentiality, you have to make sure and express to them there are exceptions to the confidentiality, and that is if there are threats present, such as the threat that they might commit suicide, or the threat that they might kill somebody, or if they've been sexually abused. Those kind of situations where there's harm involved, the nurses legally responsible for reporting such activity. Now the elderly, you have to keep in mind some of the physiological changes that are going on with the elderly and accommodate for these. So, speaking slowly, if they're hard of hearing, if they have trouble seeing you or visualizing what you're trying to teach them, we just have to try and accommodate for those aging changes. So when we talk about our mental health status exam, this is the area right now where in our pre-class handout, I asked you to have an index card ready so that you could write down the components of this assessment, the nursing assessment, so that you can utilize it when you're on the mental health unit, so that you make sure not to miss any of the components that we should be looking at. But basically, the nursing assessment in a mental health situation is going to be more focused on discussing and observing rather than, focusing on physiological changes. It's more interpreting and listening and hearing what the patient is telling you about their condition. So the first assessment criteria is appearance. So you want to be looking at their hygiene. How are they dressing? Are they dirty? do their clothes not match, or are they eccentrically dressed, or are they dressed perfectionistically? Okay, those are all things that are going to lead you to some clues about particular disorders. Look at their pupils. Are the pupils dilated or constricted? Again, that might clue you into some kind of substance abuse. Facial expressions and posture. Are they in a fetal position? Are they avoiding eye contact? Or are they very suspicious, looking around? You want to be looking at their nutritional status. Do they have any skin marks, such as scars or tattoos or things that would lead you to believe there's some abuse or some self-mutilation going on? So that would be appearance. Next criteria is behavior. So what you're looking for in the behavior criteria is body movements, eye contact, their attitude. Are they cooperative or uncooperative? Are they friendly? Are they hostile? Are they defensive? Are they guarded or suspicious? And finally, impulse control. Are they aggressive? Are they hostile? Are they fearful? Do they appear guilty? Do they show affection? Things like that. Okay. Next category would be speech. Is their speech of a normal rate, volume? Or is there cluttering of their speech, or what sometimes we call a word salad, which we'll talk about later? What the rate of the speech? Is it too slow or is it too fast? The volume. Are they really talking loudly, or is their tone defensive, or is their tone aggressive? Things like that. Next category would be mood or affect. So mood would be like sadness or giddiness or euphoria, as we call it. Do they have a sustained emotion, or is it extreme? Does it interfere with how they view the world? Is the affect flat? Is it angry? Is it withdrawn? Is it animated? The external manifestations of feelings or emotions, which are manifested in facial expressions or tone of voice or body language. Okay. Next category would be disorders of thought. So is their thought process logical, organized? Is it coherent? Do they have flight of ideas? Do they have thought blocking, where they'll be talking and all of a sudden they stop and don't go any further? Are their thoughts content appropriate, or do they have delusions or obsessions or suicidal thoughts or paranoid thoughts or suspicious or magical thinking or fears? The next category would be perceptions. Okay, that's perceptions. Disturbances would include things like hallucinations. Hallucinations can be auditory or they can be visual. Hallucinations basically can affect all 5 of the senses: tactile, taste, olfactory. And the nursing diagnosis related to this obviously would be altered perceptions. Are there illusions present? Next category would be cognition. So what is their a level of alertness? Are they conscious? How's their memory? How's their attention? Are they able to have insights and make judgments? How's their ability to solve problems? How's the ability to make decisions? Do they have knowledge of themselves? Do they have adaptive or maladaptive coping strategies and defense mechanisms? Next would be ideas of harm to self or others. That one is pretty self-explanatory. And finally, your psychosocial assessment is going to include, and I like to use acronyms, so I use HEADS, which is HEADSS. The H stands for home environment. The E stands for education and employment. The A is activities. Are they involved in activities? D is for drug abuse, drug, alcohol, or tobacco. S is for sexuality. What are their practices? What do they see as socially acceptable? And the next S is for suicide risk. And the last S is for savagery. And what that means is abuse or violence in the home environment or in the neighborhood. So the next slide, hang on. I'm not progressing here. So what happened? Hold on. Oh, I am completely, okay, wait. Something just went all goofy. Okay, let's try this again. That's the slide we were on. Oh, it's just slow. I'm sorry, sometimes technology just doesn't like me. Okay, so these are the things that we just talked about, that you're going to make your index card for clinical, right? This is an acronym. Sometimes I suggest to students when you're making your index card to try and remember these categories of the assessment. Now, it's called BAT caps, but I include an additional P and S at the end. So B is going to capture your behavior category, A your appearance category, T thoughts, C cognitive, A affect, and P perceptions. But then the additional P would be your psychosocial, and then the S at the end would capture your speech component that you're trying to assess. So the nurse-client relationship, right? We're trying to establish a therapeutic relationship. Again, we want to do that milieu therapy in which we establish an understanding that the nurse is safe and the patient is safe, that we're confidential, that we're reliable and consistent, right? The nurse-patient relationship, basically, the goals are to facilitate communication. You want the patient to open up and tell you about any distressing thoughts or feelings that they're having. The goal for the nurse would be to assist the patient with problem solving, facilitate activities of daily living, help the patient examine self-defeating behaviors and to test alternative ways of coping, promote self-care and independence. Again, safety is going to be a number one concern for you, and you're going to want to remember that. Safety is number one. We need to protect the patient, and this is an essential first step when meeting any patient. We have to make sure that they are not a harm to themselves or to others. And then from there, once we know they are safe, we can move on to start building this therapeutic relationship with the client. So factors that benefit the nurse-client relationship are listed there. And this is something that will build over time, right? This is, initially on that first initial meeting, that patient is most likely not going to open up to you. But if you do consistent, regular, brief interactions with the client, you're going to build that trust with them over time. The third bullet point there, letting the client set the pace, right? This is very important. Don't push. If we push, that tends to backfire on us and we end up going back 5 steps. We just need to be there, offer ourselves to them, and let them set the pace of what they want to share with us. Sometimes just sitting with the patient and not badgering them or asking them a million questions, but just sitting and interacting with them, playing a game of cards, or if they're coloring, just color with them. Those types of activities, offer yourself to them without pushing them. There, of course, are factors that also hinder the relationship. And I know you can read, so I'm just going to let you review those on your own. I do want to just mention to you that I did post in Blackboard therapeutic communication techniques and non-therapeutic techniques that block communication. So it would be a good idea if you would review those. I know that you have used these and learned about these in past courses, so I didn't want to, go through them in depth with you, but please do review that document. Okay, finally, the phases of the nurse-client relationship. This is an area that you're going to want to understand, that there are phases to the relationship. The pre-orientation phase is really where you're not involved with the client, but you are identifying your own biases or feelings that you might have towards mental illness, any fears, because all of those biases and fears are going to show in the way that you communicate with that individual and through your body language. The other thing that occurs in the pre-orientation phase is that you're reviewing this patient's medical history and situation so that you have a good understanding of that client before you meet them, and you have a plan for how you're going to approach the interaction. Orientation. This stage is an interactive process where you set up all kinds of goals, but it is a mutual setting up of goals, right? You're building that trust, you're talking about goals, but you're talking about goals that are important to the patient. Now, I could set up all kinds of goals for you guys in this course, right? And I kind of do, but, if, say, I set a goal for you to stop smoking by the end of this course, and you weren't really interested in stopping smoking, I could write goals all day long and they wouldn't mean a thing unless you, the person who has the goal, buys into it or also has the same goal as you do. Okay, the next phase is the working phase. This is really where trust has been established. You're just maintaining that relationship, and now you're going to get down to, really problem solving and facilitating change with that person and helping them develop positive coping behaviors. When you're through the working stage, the final phase obviously is termination. This is a summarization of what you guys have accomplished, reviewing the plan, showing the patient how far they've come. Now, depending on the mental illness, this can be a very difficult time, especially if the person has, say, a mental health disorder that involves dependency, right? This is going to be very difficult for the patient to end this relationship with you. So it has to be handled very cautiously. But in the end, it does have to end. They do have to move on, and you've given them the tools to be able to move on. Okay, that ends this session. The next recording will be on communication.